So this picture here is one we took last summer. My daughter has always been very into Greek mythology. A lot of us with a Western education, this is something we learned from very young. And this is actually a picture of the ruins of the Temple of Apollo in the mountains of Delphi. For folks who know the Greek mythology, this is the site of the ancient oracle at Delphi. And the ancient oracle is where travels came from far and wide and seek of advice and seek of guidance and wisdom. And in coming there, some travelers left with wonderful advice that helped set the tone, and their civilizations prospered for generations. Others, maybe they got bad advice or a bad prophecy, or maybe they interpreted it poorly, and they saw the demise of their civilization. And many other travelers came and actually left more confused than when they came. It was very difficult to interpret. Oftentimes, and as I was taking this picture, I was thinking of being in academia and people looking for advice and thoughts on the future. And it just made me think that even though most people leave more confused than when they came to me, it's probably not the worst outcome. So. But translating this into today, you know, it still remains elusive, the ability to predict with certainty what is going to happen. And so here are a couple of examples in the health and healthcare sector from COVID-19. So this graphic up here with the red box is from the New York Times in, I believe it was in March of 2020, about the COVID-19 pandemic. And essentially trying to predict, based on 2 data points, how bad the pandemic would be. And those 2 data points were, how infectious is it and how deadly is it? And based on the variability of the information, it was somewhere between a bad flu season, polio, and almost as bad as the 1918 pandemic, arguably one of the worst pandemics in human history. So a huge spread in terms of uncertainty and the need for additional information to help frame what this is. This middle graphic is one where we did some work actually looking at just one of those data points, how infectious it is, right? Coming from other studies that were looking at the R0 value, essentially if one person is sick, how many other people will they make sick? And you see it's very spread out early on, and then as time progresses, we get better information, it starts to coalesce, we start to get a bigger picture. But it never unifies around a single point, because there's all this other variability out there, right? If I'm on a crowded subway car with nobody with masks and I'm coughing, right, I'm gonna infect a lot more people than if we're walking by each other at the park and have a very casual sort of outdoor, right? So there are variables even when we know sort of the clinical behavior in the social environment that affect this. And this last one, which you can't read, which is not a problem, but is essentially we were working to inform a model for workforce absenteeism for an electric utility. And the gray boxes are data points we could find in the literature, and the white boxes were ones where we couldn't. So just a quick example, we knew the average hospitalization time, how long someone would be in the hospital if they had a severe case. We didn't know and couldn't find, after they were discharged, how long until they could go back to work. That depended on a lot of other variables that we didn't have access to. So this gets us to this point where we build deliberate strategies. We build deliberate pathways on where we're going to go, and then reality sets in, right? And we have to throw out a lot of the plan because a lot of the behaviors that people were working with, that the agents were dealing with in terms of the disease agents, they're not following the plan, so we have to develop new plans, and we have what's called emergent strategy. And there are techniques we've drawn from this that we've integrated from the private sector. One of them is first defining the game. What is our role in doing this? Are we in healthcare delivery? Are we in policy? Are we in supply chain management? And then the other is defining the fitness criteria. So for the fitness criteria, I take it to this case of a colleague of mine in a paper we put together looking at a multifaceted disaster at a hospital. So it was during the COVID-19 pandemic, during a chronic healthcare workforce shortage exacerbated by the pandemic, and then a cyber attack on the hospital, a ransomware attack. So all of a sudden they had 3 different areas of planning, 3 different areas of strategy that were now overlapping and creating new sort of new notes. And if you look around the edge here, what are the prerequisites for managing this? You have the plans for how to deal with it. Normalizing rest and support, investment in infrastructure, culture of safety, supporting trainees. This is the fitness criteria, right? We don't know what's going to happen, but to improvise, to adapt to those emergent situations, these are the prerequisites for having that agility, for having that adaptability. To look at this from another angle, there's this term, another term we borrowed from the business sector called the strategy paradox. I first came across this through a book by Michael Rayner of the same title. And the strategy paradox is that often we have to make commitments before we have enough information in order to make those commitments, right? That's life, right? Oftentimes we're faced with this choice. And two of the lessons that I think are particularly important from the strategy paradox are, one, oftentimes we actually make decisions too early. We make decisions and we make commitments when actually we should be managing our uncertainty. We should be creating options that we could exercise at a later point when we have more information. And the other is, while there's a lot of sort of uncertainty, there are boundaries of that uncertainty. We have a sense on the upper and the lower parameters. So this isn't just a nice theory. This is something we've integrated into practice, and this is an example of some work we did with a large city's health department. And so over here, what you have is a traditional nested framework for planning, right? You have capabilities that are broken up into strategies, that are broken up into operational objectives, procedures, activities, and more specific. And somewhere in here, we wedge in our uncertainty dimension. And what are the upper and lower boundaries? So let's talk about COVID again. Right? Let's talk about the resources we have to combat it. So, a best case scenario, we have effective and available pharmaceutical interventions. Okay, with that strategy, we need procurement capabilities. We need to be able to distribute it. We need to be able to get shots in people's arms. At the lower end, we don't have it and may never have it, right? We didn't know early on in the pandemic where we were going to get with vaccines and treatments. And so in this case, we're focused on the non-pharmaceutical interventions. We're focused on masks and supply chains and getting them to people. And then there are degrees in between. So there's actually a lot we can do with this, right? There's a lot of investments we make. And even in the way we invested in vaccines, we didn't invest in messenger RNA exclusively. We invested in all sorts of different types, knowing that we didn't know which one was actually going to be the most viable. And it turns out several of them were, and some were more suitable for different environments than others. So how do we make better decisions, right? We make better decisions. This is something we borrowed from the military and integrated into health and healthcare. It's called a synchronization matrix. And so the idea behind this is that up here in the upper, your left hand, my right hand corner, is the decision that needs to be made. That utility that I mentioned that was focused on workforce absenteeism, this is the use case. This is what the work that we did with them. And they were looking at different categories, different groupings of interventions for the workforce. Very worried about critical functions where the grid couldn't operate if people weren't at work. And so with that, so up here is the decision that needs to be made. And it's usually on this is in the acceleration phase where we're seeing more cases. Up here you see the threat information and the questions that are asked. Now, if we're talking about infectious disease, we want to know things. How fast does it spread? How deadly is it? Things like that. And context are a lot of those other things, those things that I had mentioned. We could know a lot about the biology of a disease agent, but then it takes place in a system. Is there good access to healthcare? Do people rely on crowded public transportation? What are the political overlays in terms of how this is being framed? Are policies being put in place that would prevent spread if it came in? They're all things that factor the vulnerability that influences this decision. Now you see some of these are bolded. Those are the things we pulled out that can be answered by analytics. So all of the technologies you've heard about today and all week, artificial intelligence, machine learning, all of these fantastic innovations all pipe into this, giving us better information to support the decisions we have to make. But at the end of the day, this matrix does not make the decision for you. It leverages the information to find the signal within the noise, but it is still a human decision that has to be made. This isn't about better decision-making, this is about decision hygiene, better decision-making processes that lead to better decisions amidst uncertainty. The bottom half I haven't talked much about. This is more about the actions that are taken based on the decision. So we were working with leadership and an analytical team, but we've also built these with healthcare incident management team responsibilities and things like that down below. So this is really all just to say that we teach from a very young age that science always has a right and wrong answer, right? We'll probably go home and help our kids with their science homework until they reach a certain grade, and then that gets too hard, right? But there's always a right answer on the test. In the classroom, it's true or false. It's A, B, C, or D. Not exclusively, but a lot of times that's sort of how we learn, and that's how we look at it. But when in practice is science ever that clear? When in practice do we confront a problem and open the textbook and find the answer? We find the tools to help us come up with the answers. So this brings us to a more chaotic understanding of the world, right? And what chaos theory teaches us is that we can't outrun complexity. But there are patterns in that complexity, and those patterns are at all levels, the very micro and the very macro. And so if we continue our commitment to technology, to science, to understanding the building blocks of how things work, but we build systems and skill sets to deploy them in environments that embrace the predictable chaos within our societies and within the complexity of our world, then with that, we can build a more effective, a more just, and a more lasting resilience for our health and healthcare systems. Thank you all for your time, and I sincerely hope you enjoy the rest of the summit and the rest of this forum. Thank you.